Hi folks, this is John Adamson, the Reata and Documentation Guru. In case you're wondering about my surroundings, I'm sitting bedside where my son had surgery the other day. He's doing okay, he's lying next to me. Figured I'd make a video. Anyway, today I'm going to talk about how to interpret the hand dynamometer. And this is really a work in progress, as you'll see towards the end of this presentation. Some things are still yet to be determined about the use of hand dynamometer that would make your job as a therapist more complete in its use. But with that said, it's a great tool, so let's delve into it just a bit. This quote comes from a literature review of 42 different studies on hand grip, and so I thought it would be good to go over this one quote from the study. Grip strength has been shown to have predictive validity, and low values, I mean low values of grip strength, are associated with falls, disability, impaired health-related quality of life, and prolonged length of stay in the hospital, as well as increased mortality. So research, evidence-based data has shown that low grip strength impacts all of these things. And so when we get into looking at some normative data, you will see that there's opportunity for us to use that data to justify why we have to work on things like grip strength. Now, it's important to talk about dynamometers and which ones are the best. And really, as I've seen in the literature, generally the JMAR hand dynamometer is considered the gold standard. For the most part, any dynamometer that's in regular use appears to, from literature search, if it uses the same measurement criteria as the JMAR, either being pounds or kilograms of force, there's good reliability between the use of different types of dynamometers by different manufacturers. But generally, most therapists are familiar with the one that you see on your screen, the JMAR. Now, it's important to note that there are some things to consider when you're using the JMAR. For example, I found out that it requires a minimum of 3 to 4 pounds of force just to get it to register. And so if you have extremely weak patients, that might not be the best tool to pick up even incremental changes. This is one thing that probably most therapists don't get done as they should, or most therapy clinics, is JMAR expects an annual recalibration of the unit. And let's face it, we probably all have JMARs that have been in your therapy department for years on years, maybe even decades, and probably has never been calibrated. And that's going to give you a false positive or false negative report on the actual strength of your patient. And so really calibrations on any tool really should be kept up, whether it's an electrical stimulator or a dynamometer or whatever we might be using, or a Cybex machine. Calibration is very important. Most of the studies that were cited in this 42 study literature review use the second position on the dynamometer. So there's 5 gradations of width of the grip, and most people were found to feel most comfortable at position 2. Some required it going up to 3, but if we're going to standardize these things, generally we're going to use 2. Now, we know that the most comfortable grip will be found if the patient, and I'm going to talk about this more on the next page or next slide, the patient can have pressure applied at their second phalange. So that's where the grip comes from, that second one. So whatever is most comfortable for them, obviously some patients are going to need position 1 because of small hands, position 3, maybe even 4 for large hands. One thing that was found was that people that had fingernail projections or long fingernails of 1 centimeter or greater had a significant impediment of their maximal grip effort. So long nails might not give you good data. Now, if you're going to standardize something, you have to have standardized positions you do things in. And the American Society of Hand Therapists, I blanked for a second. American Society of Hand Therapists have a suggested position. So you have a person seated, they're supposed to be seated against a high back chair. Their shoulders should be back, good posture, of course. And then they want to have their shoulder neutrally rotated, their elbow at 90 degrees flexion, forearm in neutral, and that says wrist between 0 to 30%, 30 degrees dorsiflexion, or we would say the extension at the wrist. So that's optimal for grip strength. There's also a Southampton protocol, and one of the things that the ASHT doesn't do is talk about how you encourage the patient. And so the Southampton protocol also requests the person doing the test to tell the patient to squeeze hard, and then while they're doing a squeeze, which should be about 5 seconds, to keep encouraging them, squeeze harder, and then relax. The Southampton also suggests 3 trials, although research indicates that people are going to get generally the best effort on the first or second trial because their maximal grip strength will fatigue as they go on. The nice thing about using a dynamometer testing is the reliability. Any good standardized measure you're going to use should have good or excellent reliability. And one of the reliabilities we're looking for is test retest, meaning that we test the patient one time, and then let's say a month later we test them again. The data comparison we get is truly useful information to determine are they making progress or not. And the other thing, of course, in this day and age when we have multiple therapists seeing the same patient, is we want excellent inter-tester reliability, meaning that if I'm testing the patient or another therapist is testing them, or Joe Buff Schmo, personal trainer down at Planet Fitness without a fully developed prefrontal cortex, test them, the data will be the same for the same patient. So having those reliabilities is important, and dynamometers afford you that. So this is related to that study I talked about earlier. Again, with a dynamometer, we have a high predictability of disability and fall risk. The weaker somebody is in their hand grip alone, the more likely they are to be disabled across the board for functionality, and fall risk goes up. And you think about that, you often need, especially as a frail elderly person, increased grip for proper transfers. And one of the studies cited the fact that perhaps it's the most practical screening tool for a frail elderly person when you look at the other standardized tests for strength, like 30-second chair rise, arm curl test, things like that. This is a simple, easy thing you can administer to most people. Now, with that said, one of the things the studies that I looked at didn't talk about was the fact that patients got to be able to follow directions to do a hand dynamometer effectively, and so if they've got a decline cognition-wise, they're not going to give you very valid results probably. There are lots of normative scales out there, and you can look on the web, Google searches, and all sorts of entities have normative scales. And I'm trying to look at my own slide. So we've got like age normative, like this scale is kind of nice. It goes all the way from children of 6 to 7 years old, probably at the age where they can really follow the directions to do this effectively, to 75 plus. And so we can see where that patient, and these are community dwelling individuals without significant comorbidities that would impact hand function. So these are uncomplicated patients. So if you compare the mean or norm of your patient to these standard norms, you'll get an idea of just how far off they are. And you can see SD, standard deviation. You can see there's a fairly huge range sometimes within the norm. So if you've got somebody fully outside that standard deviation from the norm, that's a very statistically significant weakness that you can justify working on. And the other thing about statistical difference is you can, or standard deviation, is you can use that as a goal to work on to get them showing a true functional improvement in that area. So I tried to do a literature search on how much strength do you really need for certain ADLs, and I'd heard some people make some claims, and this is one of the things I'm hoping my viewers will help with, I could do a follow-up video to this, is how much strength do you actually need for grip for a transfer? How much strength do you need to hold up a typical frying pan? Um, things like that, things that we might want to know to correlate grip with actual function. Just to let you know, there's a study that's going to be starting in January of next year, 2020, which with projected completion by April of 2020, called The Measurement of Grip and Pinch Forces Needed for Activities of Daily Living, Work, and that's supposed to be prehistoric, not prehistoric, prehistoric stone tool production. So I guess we're going to be compared to people that made spears to slay woolly mammoths. I don't know. But anyway, that'll be an interesting study, and hopefully they'll look at a lot of ADL factors and how much grip you actually need for those ADLs. So obviously I'm a fallible human being, and my literature search might have been limited by the words I used for searching for articles. But if there are no standardized functional measures that correlate with specific function, like you need this much grip for this function, how do you write goals or analysis or document analysis? Well, like I said earlier, standard deviations might help you determine statistically different measures for your individual patient. So if your patient has a mean of 75 pounds of grip and their age normative is 100 and their standard deviation is 20 points or 20 pounds of force, if we move them from 75 to 80, technically we've moved them into the standard deviation of norm from a week, so we could write goals based on that. Obviously, age normative gives you something to shoot for on your patients, and if you've got patients that are shooting for a home discharge, knowing what a standard community-based person should be able to achieve grip-wise gives you a standard to shoot for, because that's what they need in the community. Obviously, we can try to correlate, based on our individual patient performance, weak grip with the performance of ADLs and transfers specifically. And the other thing I would just ask you to do is any suggestions you might have that would help correlate with this use of a measure. What have you seen? What have you utilized? So anyway, I have no more slides on this presentation. So if you have any suggestions, comments, whatever, please feel free to send them through my YouTube channel. This is John Adamson, the Rehab and Documentation Guru. Hoping you have a blessed day. Take care.